of the morning, obviously, the story of the day, the confirmation of the new variant of COVID-19, currently called the B11529 variant. It'll get a more simple name in the next few days, but it's been found here. The obvious question is whether the immunity that you may have from having had the disease before or having had a vaccination will work. It's a difficult question to answer at this stage. Professor Mark Mendelsohn is Professor of Infectious Diseases at UCT and Head of the Division of Infectious Diseases and HIV Medicine at Groote Schuur Hospital in Cape Town. Professor, good afternoon to you and thanks for your time. So obviously you, the scientists, doctors, still looking at this. They keep saying there's a relatively high number of mutations within the virus. What might that mean for immunity?
Well, good afternoon, Stephen. And I'm fresh from having my booster vaccine on the Sisonke for healthcare workers, so my immune system is really chipper this afternoon. So to answer your question, the viruses mutate continuously. Each time they replicate, there are slight changes in their genetic code, and most of these mutations don't give the virus any advantage, but some do. And what the virus is looking for is an advantage, both in trying to get itself transmitted more, and B, to be able to evade our immune system. And what's happened with this new variant, which will be given a Greek name, probably in the next couple of hours, is that we've got now even more mutations than we've seen in the previous variants, particularly the Delta and the Beta variant. Some of them are similar, in fact some of them are the same, but it's the number and it's the potential of what they could do that is causing some concern. Now, that doesn't mean that it actually is going to come to pass that this virus will be more clinically severe. And I think it's very important to understand that what the vaccine is really trying to do and what its primary goal is to protect us from severe disease, from being admitted to hospital and from dying. And across all the variants so far, the vaccines have stood up. And there's nothing to suggest from these mutations at this point in time that that won't continue. The question is, will some of these changes allow the virus to evade the immune system in so much as it may cause more mild infections or even asymptomatic infections? That we don't know yet. It's the possibility that's causing the concern.
So it's unlikely, I think it's almost impossible that the vaccines give us no immunity. They're going to give us quite a lot of protection because even though it's a new variant, it's the same disease.
Absolutely, 100%, Stephen, and I think this is something people really need to understand. As I've said, the primary aim of this vaccine is to protect you from dying, protect you from getting severe disease, and protecting our health system by reducing hospitalizations. It isn't primarily there to reduce all transmissions. Obviously, we'd love a vaccine to be able to do everything. But the message is still the same. These vaccines work at protecting you against the severity of this disease. So every South African should be vaccinated, and all healthcare workers, people who have immune suppression, and I also think in certain age groups over above 60, should either be vaccinated or boosted at this stage.
Can different variants have different symptoms or more intense symptoms or less intense symptoms? You made the point earlier that viruses mutate because they want an advantage. It's not an advantage to have a more severe symptom. It's actually an advantage to have a less severe symptom, if I've understood it correctly.
Well, indeed, the virus doesn't want to kill you. It actually wants to stick around as long as possible so that it can infect as many people as possible. And therefore, some mutations, although the transmissibility may increase, the severity of illness that a variant can produce sometimes does decrease. Now, we're not going to know that about this variant until things have played out. Unfortunately, we're going to have to see the cases and see what happens to be able to give you that information. But it's not a given that mutations and changes in the virus, and particularly this mutant, will be more clinically severe.
So do we have to wait to see what happens in the population with this variant? Or is there clinical work that can be done, I imagine may already be being done in laboratories here and in other places, I imagine KwaZulu-Natal, Cape Town, around the world, to look at the test for immunity? If I remember when we had the Delta variant, we knew quite quickly that the vaccines would still work? I mean, we didn't have to wait for the variant to go through a population first.
Well, again, I think one has to separate out what one means by vaccine working. So there's these sort of two parts to the jigsaw. One is whether the vaccine will protect against infection and mild disease, and that's really what people often concentrate on. And we talk about the neutralizing antibodies, these proteins in our body that hunt the virus and attack it and stop it causing too much severity. And the other part of the jigsaw, which is the severity, which is slightly more than, it is more than just neutralizing antibodies. It's a whole complex immune system. So the neutralizing antibody side is easier to look at in the laboratory, and already the excellent scientists in South Africa are already on that and starting, and we should have that information within the next days to couple of weeks. But the issue of severity is more difficult and really does require a period of transmission, of people being ill, and then understanding how many are hospitalized. When you are hospitalized or you are a case, have you been vaccinated before, yes or no? We know with Delta and all the others that you are much more likely to get severe disease, be hospitalized and die if you were unvaccinated, which again is a really strong indication that the vaccine protects you. And so every South African should go out and get vaccinated.
So we have, I think, around 35, maybe 36% now of our population is fully vaccinated against the disease. I realize that definition may sort of change slightly, but that's the definition we have at the moment. So 35%, a lot more, I think it's close to 50% are partially vaccinated. Then we've had what I suppose we would call exposure to COVID-19. In other words, people have had the disease, they've been exposed to it, they already have an immune response from their bodies. In my case, as an example, I've both had the disease and been vaccinated. So, and I mean, there'll be millions of South Africans in exactly the same position as me. The point I'm trying to get to is that, do we think within the community, I realize Professor Shabir Mahdi has suggested today, for example, we must be very careful about the phrase community or herd immunity. But the fact is there's a lot of immunity in the system, a lot of immunity in our population that wasn't there at the start of the pandemic. I presume that means, hopefully, we could still, worst case scenario, still won't be as bad for our hospitals as the first, second or third wave.
Absolutely. So the studies suggest or show that if you've had COVID through natural infection and you've had a vaccine, that you are probably the most protected that you're going to get. So, people like yourself actually are very well protected. Now, it rather does depend on when you were infected and when you had the vaccine, because we know that immune responses do wane over time, but that protection against severity is likely to still play out. So we know that this is a new variant. We know that it's in South Africa. We know that the majority of the cases that are now starting to be seen in Gauteng and a couple of other provinces are this new variant. What we don't know is what the effect will be, as you quite rightly say. You can model that by making assumptions. You can say, okay, if this variant does turn out to be twice as transmissible or 3/4 as transmissible as the previous one, and if we reduce if we're not so good at our public health interventions, you can make assumptions and you can model. You can come out with what it looks like in terms of the number of hospitalizations. Now, those models make assumptions, but they're relatively accurate. And it does range from the scenarios that have been seen and presented, does range from really not too bad impact on the health system. But the other scenario is that actually there is quite a hit to the health system, and it may look rather like it has in the past wave. And we don't know how that's going to play out. But the surest way of affecting that at the moment is twofold. One is to get vaccinated if you haven't been vaccinated. Even if you had natural infection, go and get a booster, which is in effect what it is. Go and get a vaccine. And the second is not to now stop using public health interventions. Social distancing. Try and stay away from poorly ventilated indoor activities, particularly those with mass gatherings. Hand washing, all these things that there's nothing new, There's nothing new because it works. Okay, so they go hand in hand, and that's what South Africa needs to do right now.
Professor, I realize you're a professor of infectious diseases, not necessarily of public health. Obviously, there's a lot of commonality between the two, and there's a lot of difference. But we're seeing reactions from governments around the world. Our National Coronavirus Command Council is meeting on Sunday, and there are probably two things they have to consider. The one is the news of the new variant. The second is the rise in new cases, over 2,400. But we're seeing the British Daily Telegraph newspaper, for example, I have a report in front of me calling the variant found here the South African or the Southern African variant. And that's in a story about it being discovered in Belgium this afternoon. How would you advise governments to react to this?
Well, firstly, it's a really sad reflection that the world has not learnt from everything that's gone on in the last year or two, and the fact that, you know, we don't stigmatize countries for the appearance of a variant, because South Africa has an exceptional sequencing capability and is likely to pick up something far more easily and quickly than other countries. We don't know where this originated, whether it was from South Africa or not at the present moment. And so for people to talk again about it being the South African or Southern African variant is really disappointing, as has been the reaction from international governments, particularly the United Kingdom, and now a lot in Europe are following suit. It is really questionable the role of shutting borders has in controlling these epidemics and the pandemic in general. Very, very questionable. And it's not, you know, I've heard over today that people saying that the South African scientists and government were wrong to share the information. That is not the case. What is wrong is an international response. And I think these countries really need to reflect on what happens to a country when they do make these border restrictions. I mean, what is going to happen in the next 3 months to the tourism industry and the people that are working in the tourism industry losing their livelihoods even more than already has occurred? You know, the numbers are going to be, you know, really significant. And these, you've got to be absolutely sure that these border controls and, you know, putting countries on the red list actually really play a role. And the evidence to date does not suggest that. And so I think it's really time to call out countries like the UK that has made this this intervention.
Professor Mark Mendelsohn, I really appreciate the time. Thank you.